Hi, it's Alex Zubarev for Casey ICU Primary Study Group. We're now moving to the next topic, which is distribution and protein binding. Questions on protein binding and distribution appeared a few times in previous sittings with pass rate below 50%. There is a high chance that they will show up in the future.
Distribution is the process of a drug leaving the bloodstream and being distributed throughout the body into the organs and tissues. Volume of distribution is a theoretical concept that relates the amount of a drug in the body to the concentration of the drug. An oversimplified model of drug distribution throughout plasma and tissues is the dilution of a drug dose into a tank of water. The volume of distribution is the apparent size of the tank in which a known amount of drug distributes to produce a measured drug concentration once the drug has had enough time to thoroughly mix within the tank. According to Rang and Dale Pharmacology textbook, the apparent volume of distribution is defined as the volume that would contain the total body content of the drug at a concentration equal to that present in the plasma. To estimate the volume of distribution of a drug in the human body, we need to analyze its plasma concentration versus time graph. After intravenous drug administration, the plasma drug concentration falls rapidly at first as the drug is distributed from the blood to peripheral tissues. This is the so-called alpha or distribution phase. This phase is followed by a slow decline of the plasma drug concentration during the elimination, or beta phase. The volume of distribution can be calculated by dividing the dose of a drug given intravenously by the plasma drug concentration at time zero. This drug concentration can be determined by extrapolating the plasma drug concentration back to time zero from the linear part of the beta elimination phase. Note that the y-axis in this graph is plotted on a logarithmic scale, so that the exponential decay curve of the elimination phase is converted to a straight line. The plasma drug concentration at time zero represents the plasma concentration of a drug that would be obtained if it was instantaneously dissolved in its volume of distribution. To list factors affecting volume of distribution, we can classify them broadly into two categories: factors related to drugs and factors related to the body. Molecular weight and lipid solubility affect distribution of the drug throughout the body. pKa, degree of ionization, affect drugs' lipid solubility and hence affect its volume of distribution. A few drugs, such as heparin, are confined to plasma because the molecule is too large to cross the capillary wall easily. The plasma volume is about 0.05 liters per kilogram body weight, and so is the volume of distribution for these drugs. Some lipid-soluble drugs, such as phenytoin and ethanol, readily cross cell membranes and are distributed evenly throughout the body. Their volume of distribution approximates total body water, namely about 0.55 liters per kilogram body weight. Tissue binding. Many lipid-soluble drugs are capable of binding in the tissues or partitioning into body fat, which increases the volume of distribution of these drugs beyond total body water. Consequently, there are many drugs with volume of distribution greater than the total body weight, such as fentanyl, tricyclic antidepressants, and haloperidol. Such drugs are not efficiently removed from the body by hemodialysis, which is therefore unhelpful in managing overdose with such agents. Factors related to body. The amount and distribution between compartments of total body fluid. The amount and distribution of fat tissue. Obesity, age, sex can affect the distribution of drugs. Degree of protein binding and concentration of protein in the plasma. Muscle mass. Pregnancy. Acid-base disturbances may affect drug ionization and hence distribution. Now let's talk about another important aspect of drug pharmacokinetics: protein binding. At therapeutic concentrations in plasma, many drugs exist mainly in bound with proteins form. The most important plasma protein in relation to drug binding is albumin. Other plasma proteins, including lipoproteins, glycoproteins, and beta-globulins, have also been implicated in the binding of certain drugs. In general, Albumin binds neutral or acidic drugs like barbiturates, and globulins, in particular alpha-1-acid glycoprotein, bind basic drugs like morphine. Albumin has two important binding sites, the warfarin and diazepam sites. Binding is usually readily reversible, and competition for binding at any one site between different drugs can alter the active unbound fraction of each. Binding is also possible at other sites on the molecule, which may cause a conformational change and indirectly influence binding at the diazepam and warfarin sites. As a first approximation, the binding reaction can be described using the law of mass action. The association and dissociation of the drug-protein complex is usually rapid, within microseconds, and equilibrium between the free unbound drug, the protein, and the drug-protein complex is quickly established. The degree to which a drug binds to plasma proteins can then be expressed as the ratio of bound to proteins and total drug concentrations. This ratio is usually presented as the percentage of drug bound to plasma protein. The amount of a drug that is bound to protein depends on three factors. 1. The concentration of free drug. 2. Its affinity for the binding sites, which depends on molecular weight, pKa, lipid solubility, etc. In general, the degree of protein binding increases with the hydrophobic character of the compound. 3. The concentration of protein. For most drugs, the total plasma concentration required for a clinical effect is much less than the concentration of binding proteins. So with usual therapeutic doses, the binding sites are far from saturated, and the concentration bound varies nearly in direct proportion to the free concentration. Under these conditions, the protein plasma binding is mostly independent of the total drug concentration. So what impact protein binding has on drugs and toxins pharmacology? In theory, only unbound drug is available to passively partition into the site of action to interact with the molecular target. Correspondingly, bound drug cannot passively diffuse to the active site and is therefore unable to interact with the target. Proteins can act as depots, rapidly releasing the bound drug when the free drug is distributed to other compartments or eliminated. Pharmacokinetic impact. In theory, only unbound fraction of a drug can freely cross membranes so that protein binding may affect absorption, distribution, metabolism, and elimination of drugs. Clearance of drugs from the body can be influenced by the extent of protein binding, but the trend will depend on the route of elimination. For example, the extent of plasma protein binding may enhance elimination by supplying the drug to the liver via blood flow, while limiting distribution to systemic tissues. On the other hand, renal clearance through glomerular filtration can be slowed by extensive plasma protein binding by essentially excluding drugs from filtration. Similarly to renal clearance, in hemodialysis toxic substances are cleared from blood through passive diffusion across a membrane. Drug elimination via hemodialysis depends on the molecular size of the drug, protein binding, and volume of distribution. Drugs with a molecular weight less than 500 Daltons normally pass through the dialysis filter easily if they are not protein bound. Finally, protein binding may affect drug interactions with other drugs or substances. In theory, plasma albumin binds many different drugs, so competition can occur between them. If two drugs, A and B, compete in this way, administration of drug B can reduce the protein binding and hence increase the free plasma concentration of drug A. In reality though, at therapeutic plasma concentrations, drugs occupy only a tiny fraction of the available sites on proteins. Sulfonamides are an exception because they occupy about 50% of the binding sites at therapeutic concentrations and so can cause harmful effects by displacing other drugs or, in premature babies, bilirubin.
Clinical application. Antidepressants are among the most frequent drug classes involved in intoxications. Amitriptyline, in particular, has been identified as one of the substances that are most frequently used for intentional overdose along with paracetamol, benzodiazepines, and alcohol. The toxic effects of tricyclics are caused by four main pharmacological properties: inhibition of noradrenaline reuptake at nerve terminals, direct alpha-adrenergic block, a membrane-stabilizing or quinidine-like effect on the myocardium, anticholinergic action, Tricyclics are rapidly absorbed from the gastrointestinal tract and undergo first-pass metabolism. However, gastrointestinal absorption in tricyclic overdose may be delayed because of its anticholinergic effect and inhibition of gastric emptying, and significant enterohepatic recirculation prolongs the final elimination. Despite its small molecular weight, amitriptyline is not considered to be dialysable due to its high protein binding, 99%, and a large volume of distribution, 19 liters per kilogram. The extracorporeal treatments in poisoning. Extrip work group, therefore, recommends not to attempt extracorporeal removal of TCA, as this approach is not likely to offer a clinical benefit.
In contrast, lithium, a very powerful anti-manic medication with a narrow therapeutic index, has a volume of distribution roughly equal to the total body water, which is 0.6 liters per kilogram, and is not bound to proteins. Relatively low volume of distribution and high water solubility render lithium dialysable. Hemodialysis is used in cases of severe lithium toxicity and is highly effective.